Okay, we're gonna get started again. It's my pleasure to introduce virtually Dr. Andrew Bauer. Dr. Bauer is a pediatric endocrinologist and professor of pediatrics at the University of Pennsylvania and the director of the Thyroid Center at the Children's Hospital of Philadelphia. Dr. Bauer's research interests span the spectrum of pediatric thyroid disorders with a focus on thyroid cancer, familial thyroid cancer, predisposition syndromes. Dr. Bauer is a medical consultant for the Thyroid Cancer Survivors Association and the International DICER Registry and works closely with the PTEN Hematoma Tumor Syndrome Foundation. In 2022, Dr. Bauer and his team launched the International Child and Adolescent Thyroid Consortium to improve collaboration across pediatric centers. Dr. Bauer maintains active membership in the Endocrine Society, the Pediatric Endocrine Society, and the American Thyroid Association, where he currently serves as the co-chair of the ATA Pediatric Thyroid Nodule and Thyroid Cancer Guidelines. He also recently served on the American Association for Cancer Research Cancer Predisposition Committee to update recommendations on the surveillance of pediatric patients with PHTS. And without further ado.
Hi, everybody, and my apologies for not being there in person. It's always nice to be in person, just a little bit of a crazy week with travel and clinic. So what I hope to do today is hear from you, because every time I talk to families, patients and families, I want to learn what it's like to be going through what you're going through, but also to hopefully educate you on some of the things and words and concepts that you may have heard as you're going through the journey of PTEN, in particular, of course, in thyroid, which is my area of focus. And so there are some changes we've absolutely learned along the way, which is true for everything in every field that people are involved with, but in particular in medicine, because we certainly don't know everything, and that's still true today. But as my involvement in trying to improve taking care of kids and teenagers with PTEN over the years, it's really been a nice learning curve, and I want to update you at least on where it stands, a little bit of data specific as well. So at the end, I know there's a question and answer period, and I'm really open to hearing from you, and also even if we don't have time, just to contact us through my thyroid center in Philadelphia, because I am interested and available to help provide care for patients with PTEN. So a little bit of concepts is really going to be the focus, and hopefully it's not too basic, and hopefully it's somewhere in between too basic and too much. But let me know, and I'm happy to take questions along the way. If there's things in the chat, I can't multitask and check the chat and give you present my slides at the same time, but feel free for someone just to interrupt if there's something along the way. So PTEN, you've gone over what, and you already know, you're living what PTEN is. But we're going to just focus on the thyroid nodule and thyroid cancer portion of it. So this is one slide showing you the whole spectrum. You start with a normal thyroid and something happens to it. And one of the most common things that can happens in patients, actually all these things happen in patients with PTEN or not with PTEN. So autoimmune thyroid disease, which the eponym for the most common form of it is Hashimoto's thyroiditis, which is hypothyroidism, where the immune system attacks the thyroid and it stops working so well. That actually has an increased likelihood of happening if you have PTEN hematoma tumor syndrome. As far as thyroid nodules, absolutely an increased risk. And it's not just for unifocal, a single thyroid nodule, but for multinodular goiter. And that number you can see on the screen is somewhere between 30% when you're in the pediatric age frame and maybe up to 70% as we journey through life. And the likelihood of it being a thyroid nodule that we need to do something about, further evaluate through a biopsy to help make a diagnosis to figure out if it's a thyroid cancer, that happens in about 35% of patients. And that's the part I hope to educate and actually hear from you about. because as we've learned over time, there's a difference between the types of thyroid cancer. And I'll give you the specifics about that as we move forward. So 65% chance that you will develop a nodule that is not a cancer, it's benign. And if you develop a thyroid cancer, 35% over your lifetime, and that's recent data from the PTEN registry from Cleveland. The two forms are papillary thyroid cancer and follicular thyroid cancer, which I'll explain on a different slide. Why a nodule transforms into a thyroid cancer is not known, but there are drivers, things that allow the pathways within these cells to gain the ability to grow in a dysregulated fashion. PTEN is one of those drivers. But even within PTEN, why do some patients develop thyroid cancers and why do some patients, not develop them? That's under current investigation. So the majority of nodules are benign, not a cancer, even in patients with PTEN, which means not every nodule needs to undergo a biopsy and or surgery. And that's the mission, is to identify who benefits from further evaluation. And it all starts with ultrasound, as we'll go over, and I'll give you the terms and how we interpret ultrasound so you're better informed when someone presents you with data about yourself or a loved one in your family. So patients with PTEN have an increased risk for bilateral disease. So that's multinodular goiter. There's kind of a loose definition. If you have more than one nodule, like that's a minimum definition of multinodule goiter. But most patients will develop 3, 4. I've seen patients with 10 and 12 nodules where there's really almost no normal thyroid tissue. It's just a thyroid gland that's filled with nodules. And in PTEN, most of the nodules actually have similar appearance, which gets back to, if you're going to have a biopsy and you have 10 nodules, you probably don't need to have all 10 of those biopsied. So you're likely to, if you have it on one side of your thyroid, to the other side. And I'll show you just a cartoon of what your thyroid looks like so you understand that. So thyroid nodules and thyroid cancers do not cause symptoms. And that's, again, a difficult part. Whether you have PTEN or whether you don't have a known explanation, sporadic, we call that, it just developed, or you have a radiation-induced thyroid cancer, there really are very few symptoms, if any, associated with thyroid nodules or even thyroid cancer. If you do blood tests, again, not super informative. We can send a TSH, you can send a thyroglobulin, which is a tumor marker, but they don't help you in the preoperative diagnosis. Most patients have a normal TSH, and the TG may or may not be elevated. If you have autoimmune thyroid disease, it will be elevated. And whether it's elevated or not, it still doesn't help determine if that nodule is a cancer or not. That test is only helpful after you know you have a thyroid cancer and after you've had surgery. So there are no lab tests that can help you. It's the ultrasound and then what do the cells look like under the microscope that helps us determine if it's something that is a thyroid cancer. So here's thyroid cancer. It's a pretty broad landscape that falls under this. So there's differentiated, that means it came from a thyroid cell and then it turned into a thyroid cancer. And the two most common forms are follicular thyroid cancer or papillary thyroid cancer. And that has to do what they look like under the microscope. There are different reasons to develop it. As I mentioned, sporadic is we don't know, it just happened, radiation induced. So radiation exposure can do that. And then there are certain families where there's an increased risk of having thyroid nodules and thyroid cancer. And as you can see from the slide, PTEN is at the top of this list. Probably not only because we're talking about PTEN today, but also probably because of commonality. So it's probably the most common familial form of differentiated thyroid cancer. Within follicular thyroid cancer, then we have to determine like what's the likelihood that it might spread outside of your thyroid. And those are the 3 levels. So minimally invasive means there was a scar tissue around it and the cancer was growing through that scar tissue, around it, but not outside of the thyroid. So there's no risk for regional or distant spread, metastasis. Angioinvasion means it went into blood vessels, and then it depends on how many blood vessels. Papillary, if you follow that line, this only shows 7, but there's actually 13 types of papillary thyroid cancer. The most common within PTEN, which I'll show you, is encapsulated follicular variant. So within PTEN, you can have follicular thyroid cancer, a little bit more common than if in sporadic than if you didn't have a predisposition, or papillary thyroid cancer. And if you looked at all the numbers, again, from the Cleveland registry, more patients will have papillary thyroid cancer than follicular, but compared to the general population, there's a higher likelihood of having follicular compared to the general population. Medullary and poorly differentiated thyroid cancer have nothing to do with PTEN or anaplastic thyroid cancer at the very extreme as far as aggressiveness. So there are guidelines to say, what do we do? And I'll show you towards the end what those guidelines define. But most recently, we just went through and currently accepted for publication, tried to redefine when we should start surveillance of the thyroid with ultrasound in patients with syndromic forms of thyroid cancer, including PTEN. And I'll present that at the end as well. So there's a difference, and this is a really important part of trying to understand how PTEN and thyroid relate to an individual person. There's a high risk to developing a thyroid cancer. I don't think any one of us could argue that 35% is not a high risk to develop a cancer. But then there's a high risk to develop an invasive or a non-invasive form. So even if you're going to develop a thyroid cancer, what's the likelihood that that cancer is going to spread? And as we'll talk about, it's very unlikely in patients with PTEN, which is a big benefit for us. So we have to think about surveillance within this context. We want to catch things early, because if you catch things early that are going to spread, then the likelihood of surviving it, curing it, achieving remission, or even a step back, how much you need to do, whether it's surgery or additional treatment, to get rid of that cancer changes. So the earlier, the better. For a patient that has a cancer that's unlikely to spread, we may not want to do too much too early, because if it's not going to spread and we kind of wait and see what's happening for that person, balanced between how much is it driving all of us crazy as far as the anxiety scale, I call it the lose sleep scale, well, then there's a benefit to waiting, because waiting doesn't make it harder to get rid of, or nor does it increase the likelihood that it's going to spread. So that's where we have to think about PTEN within that balance. And in the middle of the balance is the comfort level of the provider, more importantly, the comfort level of the individual patient and the family, and both those things together as a team. So it really does take discussions and understanding things, and that's what I hope to give you in the next 10 to 15 minutes, so that you're better equipped to go into these meetings with your provider, endocrinologist typically, or head and neck surgeon, knowing what the risk is and knowing what the words are when they're thinking about, should we biopsy, should we do surgery, should pursue surgery. A nodule is a nodule is a nodule is what this slide essentially is saying. So whether you have PTEN or not, there's certain things that we look for on ultrasound to say, should we biopsy or not? There are guidelines, and it's a risk stratified approach. So in pediatrics, there are guidelines that we're currently revising. We published them in 2015, and these should be out, the revised version, in 2024, next year. And the adults have a separate guideline as far as the American Thyroid Association. So within thyroid, within the United States, North America, the American Thyroid Association has the most complete and informed guidelines for how to evaluate thyroid nodules and thyroid cancer. So let's start with ultrasound. It is absolutely the most critical first step in evaluation and diagnosis. You may not feel a nodule on exam. Ultrasound is way more sensitive at picking up nodules, and there's ongoing discussion whether you pick things up that are more, that you might overpick things up by ultrasound. Most of that concern is because people have struggled with interpreting ultrasound images, and then they worry about biopsying things that may not benefit from biopsying. But in the hands of someone who's performing an ultrasound that understands thyroid disease, and in someone who's interpreting the images, ultrasound is absolutely the first step and a really critical step to the next, to if you should pursue the next two: fine needle aspiration biopsy, FNA, and or surgery. So here's the thyroid in cartoon version. It has a right side, a left side, and a little piece in between that isn't called the little piece in between. It's called the isthmus, which just means the bridge. So you can have a nodule on the right side. You can have 3 nodules on the right side. You can have nodules on the left side. If it's only in one side, that's unilateral. If it's in both sides, it's bilateral. And then there's the thyroid system, which is a feedback loop. Just like all of endocrinology, You have a place in your body that makes a hormone, T for thyroid, 4 is 4 iodines, 3 is 3 iodines, and then a place in your body that measures it and tells the thyroid to work through a stimulating hormone, in this case, thyroid stimulating hormone. So when we talk about hypo or hyperthyroidism, we're talking about the T4, T3 levels. So in hypo, the T4, T3 go down and the TSH goes up. It's a feedback loop. Vice versa, if the T4 goes up, the TSH goes down. The medicine, if you're on thyroid medicine that you take, is T4. T4 is levothyroxine or Synthroid. Here's what a normal ultrasound looks like. So if you put the transducer across your thyroid, you'll get this image to your right. So the normal healthy tissue is bright gray. The round thing in the middle is your windpipe, your trachea, and then the normal healthy tissue here is the left thyroid lobe. And the little piece that connects the two pieces is the isthmus. So that is a normal thyroid ultrasound. If you turn your probe 90 degrees, this is what normal thyroid looks like in sagittal or long view. So two different ways at looking at thyroid. The ultrasound can tell you a lot, but it can't tell you everything. So if we say, is there some thyroid lesion that you don't have to worry about, it's a cyst. A cyst is a nodule, but there's no cells. All it is fluid. So that's the only thyroid lesion that has almost no risk. And in medicine, we rarely say 100% or zero, but it's pretty close to 100% that there's a no risk for this. So these can be cosmetically annoying, but they're rarely clinically concerning. And we all have these little teeny ones here to the right, which is called a colloid cyst. And oftentimes in colloid cysts, they're not water, they're stuff that's floating in them. And if the stuff vibrates, you'll get a bright spot. And I've seen over and over again that bright spot miscalled as a microcalcification, which is a worrisome thing. But these are not microcalcifications. These are just colloid artifact, we call them. They're a bright spot with a little tail, like a comet going through the night. So these are two examples of cysts that any one of us could get, whether you have PTEN or not. No concern, no need for biopsy. As you start to add cells to the nodule, the level of concern increases depending on what the shape, the echogenicity, the margins. There's 5 things, which I'll show you on the 2 slides from now, called TIRADS. That's interpreted under this thing called TIRADS, determines the risk. This one up here is low risk. We call it a spongiform. You can imagine you cut through a sponge, it looks like that. We're not very fancy. It's a spongiform nodule. This one's complex. The black is fluid, the solid is gray. These are lower risk than solid. So as soon as you start getting to a solid nodule, the risk starts to go up. So we can use the ultrasound. Is it cystic? No risk. Is it complex? A little bit of each. Solid, cystic, it's a little bit higher risk, depends on what the solid portion looks like. Solid completely, the risk goes up a little bit, but not super high. And then we start to look at lesions that are more concerning, more consistent with a thyroid cancer. These again are very dark gray, but you can see they have kind of funny shapes. So here's when we say this is lobulated. It's like a lobe or a little area that's jutting out into the healthy tissue. And it looks like it's potentially blurring this margin a little bit. Here's one with bright spots that are microcalcifications. And here's a patient, that's their left lobe, and this is the side of their neck that actually has a thyroid cancer with a lymph node metastasis. So the ultrasound is really important. What does a nodule look like? And there are features that we look at: composition, what's the grayness, dark gray, same gray as healthy tissue, what are the margins, what's the shape, and are there bright spots that look like microcalcifications? And all of that is captured under TIRADS. So TIRADS is just a system. It's not 100%. It's only as good as the person who's capturing the images and interpreting and assigning points. And that's all TIRADS is. It's nothing magical. It's nothing fabulous. It's just a system to grade 5 features of the nodule that then allows you to say, should we biopsy or not? So that's all TIRADS is. So ultrasound is only as good as the person obtaining and reading the images. And oftentimes in radiology, the person obtaining them, the techs, which are fabulous people and very good, they're not involved with interpreting and they're not involved clinically. So they have less understanding compared to your endocrinologist. So point of care ultrasound by endocrinology or surgery oftentimes is more accurate than in diagnostic radiology. If we move to the next step, And I want to show you this because anytime that someone wants to put a needle into me, I want to know if they're gonna, what's the answer going to be, right? You don't want to have a test that you don't know what the answer is. And the problem with cytology, which is a good and a bad problem, is it's a very skinny needle and all you're getting are cells. And this is just an example of what these slides look like. So they're groups of cells, and it's a needle that sometimes you don't need a Band-Aid for because it's such a small puncture wound, but it's not a yes or a no answer. There's actually 6 possibilities. One, you don't get enough cells. That's a Bethesda 1. Bethesda 5 or 6 is a cancer. And then there's some in between. It's not a normal, there's a benign, that's a Bethesda 2. And then a 3 and 4, that's not cancer, and it's not cancer. And so it really does matter who you're selecting for FNA because it's not a binary system. There are interpretation, just like the ultrasound gets interpreted, the biopsy gets interpreted. And the better the person in the higher the risk for malignancy, and the better the person who's interpreting what the cells look like, the more accurate the biopsy is going to be for an individual patient. These are the risks of malignancy within pediatrics, and there are risks of malignancies within adults. And this is all called the Bethesda system because people meet in Bethesda, Maryland, nothing fancy again. And so here's the 6 categories that Bethesda can be, and it's showing you that there's some differences between pediatrics and adult. So if you have a Bethesda 3, atypia of undetermined significance, it's the bottom of the gray zone, 15% risk of cancer in adult, almost 30 in pediatrics. If you have a follicular neoplasm, that's the upper end of the gray or mid to upper, 30% risk of cancer in adults, 50% in kids, 75 for suspicious, 81. So within that gray zone, which is 35% of our patients, and in PTEN, it's probably double that. There are different risks of malignancy, whether you're a child, a teenager, or an adult. And here's just an example of if you have a biopsy we're not listed in here, but at one institute compared to another, and you could look at the variation between risk of malignancies, all for the same Bethesda categories. As a provider, that's troubling, especially as a thyroid provider. It should be troubling to you too as a patient, because that's the variance of interpretation. You could have your biopsy in one institute and you can go to another one. Someone might say, well, there's a 20% risk of malignancy for a Bethesda 3, and the next center might say 67% risk. That's very troubling. And so it really drives home the point that it matters where you get the evaluation and who's interpreting. So in a 6-tiered system, selection of the patients impacts the accuracy, and that's just mathematics, and I'm not a mathematical genius, but if this is just a normogram showing you the lower the risk of cancer, the lower the accuracy of the test. The higher the risk for cancer, the higher the accuracy for the test. And so it's not just true clinically, it's mathematically true, and a lot of it has to do with just these broad variance in what things look like on ultrasound and the interpretation of the biopsies. Really, really important not to biopsy everybody and then who's interpreting them. And as I mentioned, 35% risk of people will be gray. It doesn't look like a cancer, it doesn't look like it's not a cancer. And in PTEN, that number is probably double just because the types of cancers that are associated with PTEN of the thyroid are oftentimes associated with indeterminate cytology. Indeterminate means that gray zone, Bethesda 3 or 4. So moving on to thyroidectomy or lobectomy. The difference between these two, and this is the last part before I just show you some PTEN stuff. A lobectomy means you remove half, you keep half. A total means you remove the whole thing. The subtotal picture in the middle, we just don't pursue very often. So you can kind of ignore the middle. It's the lobectomy or not. The risk of surgery is that if you remove the thyroid, you could damage one of the nerves that supplies our vocal cords, or behind the thyroid, there's 4 glands that control calcium. So if you remove half your thyroid, the advantage is you're not near 2 of those glands, you're not going to have a calcium problem. That's a big advantage. And you may not need medicine because you still have half a thyroid that's left. The disadvantage of a lobectomy is if you already have bilateral nodules, then you're not going to have all of them removed. You'll need surveillance. And even if you don't, because you have PTEN predisposition, you might develop nodules over time. So when I first started working with patients with PTEN, I never would have thought of lobectomy as a choice. But I think it's worth discussing if you happen to have a loved one or yourself where there's only one half of your thyroid that's affected. The drivers of thyroid cancer, and we're not going to go through all these details, but as I said, PTEN's an abnormality in a gene that's associated with taking that allows a normal thyroid gland to turn into a thyroid cancer. And PTEN listed here in the middle can form into papillary thyroid cancer, and PTEN can form into follicular thyroid cancer. And there's a bunch of other genes. It's actually within the cancers, it's a very molecularly clean cancer. There's usually only one alteration that's associated with normal to abnormal, and it actually follows a very predictable pattern. So these drivers rarely cross if they have associations with something that's less likely to metastasize versus more likely to metastasize. So as I said at the beginning, PTEN is one of these genes that's associated with a lower risk to metastasize. Nodules in PTEN are often solid. Their gray is sometimes a little darker, but oftentimes similar to healthy tissue. They usually have smooth margins, and they rarely have bright spots that look like microcalcifications. They have a very consistent ultrasound appearance, and they very consistently are associated with two forms of thyroid cancer, as you can see written there, that have a low likelihood of spreading to lymph nodes or through blood vessels to distant locations. Here's a 15-year-old who already had half their thyroid removed before they actually came to us. The windpipe is in the middle, and this patient has Hashimoto's. That's why the background tissue doesn't look bright gray like I showed you what normal is, and you can see the radiology marks outlining a nodule. This is Doppler. It just looks at blood flow. It turns out Doppler doesn't help actually predict if it's going to be a cancer or not a cancer. But when you see the colors, things on the screen, if you go over the images with your provider, Doppler provides blood flow and it assigns color based on speed and direction. So this person has half a thyroid and they have nodules that are a little darker gray, solid, smooth margins, no bright spots. So this patient had a lower risk for invasive disease. And as I said, if you go to PubMed, which is our peer-reviewed system sponsored by the National Institutes of Health, there are no real reports. I didn't put 100% because it's possible I missed one, and it's possible tomorrow there'll be one, of patients that developed regional or distant metastasis. And if you're one of these people, please let me know, because I'm here to learn and not misstate things if that's true, if you know someone in your family. As a caveat, I have patients, at least 3 patients, that have PTEN that developed a thyroid cancer that was not related to their PTEN, and they had risk for lymph node metastasis. So it is possible, even if you have a predisposition, to develop a cancer that's not related to your predisposition. We looked at years ago our experience with PTEN, and at the time, we had about 80 patients with PTEN in our practice. 58 of our pediatric patients had undergone thyroid surveillance, 52% had a nodule, 16 of these patients had thyroid surgery. All of them had their whole thyroid removed, and 6 of those 81 ended up with a thyroid cancer, which was 7%. All of them were intrathyroidal. None of them had any evidence of spread regionally or distally. And because of that, and there are other articles that you can see in the lower right corner, that's allowed me to be a little bit more confident to say this is one of those drivers that really doesn't lead to metastasis. So what have we done for surveillance? Well, we started saying you should do thyroid surveillance at 7 years of age, because that was in the literature the youngest patient that was diagnosed with a PTEN-associated thyroid cancer, and that stayed in the literature all the way up till now. The next version of the ACR guidelines, which Dr. Ng actually was involved with, helping to decide, takes our initial 7 years recommendation and moves it to 12, because again, the delay, we don't think, increases the likelihood of developing an invasive tumor. And there's even some discussion at some point if and when we should move that to 18 years of age. So I think it's an impossible task to go from 7 to 18, and I'm not even comfortable doing that, even though I have some fair comfort with it. I just don't think it would be the right thing to do after all these years to just go, from one extreme to the next. But because of the things that we've talked about and I've reviewed, there's some push to say maybe we should move it to 12 and maybe even beyond that. If you have an ultrasound that doesn't show a nodule, there's evidence in adults from the Cleveland Clinic that say you could skip a year or you could skip 2 years. Things that happen in the thyroid happen slowly. Our patients usually come in to PTEN clinics, so if they're there, we'll do the ultrasound. I do it in clinic. So to wrap things up, yes, an increased risk for nodules. Yes, an increased risk for thyroid cancer. That data is very solid. The thyroid cancer is slow growing, and the majority are not going to leave the thyroid. So if you wait, you're not putting yourself or a loved one at risk. Ultrasound surveillance, we're suggesting, part of a discussion, not just amongst professionals, but of course with patient groups as well, to move to 12. If it's normal, you could even skip 1 or 2 years if that's something that's comfortable. All of that weighed with how much does it bother you, because ultrasounds have no risk except for misinterpretation. It's not radiology, like an exposure to radiation for part of the imaging. Surgery, if someone is moving to surgery, with rare exception, thyroidectomy is the most common surgical approach. But if you have unilateral nodules, it's something that's up for discussion, and it really should be individualized based on the patient's level of understanding and ability and willingness to put up with continued surveillance. And if you go to surgery, you should ask how often they do the surgery and what their complication rate is. So individualized care based on provider, patient, and family comfort versus anxiousness. One of my missions, to wrap things up, is to help teach pediatric centers how to improve their ability to read thyroid ultrasounds. We have a course. And just to show you in our own practice, I've been reading ultrasounds since 2010, but performing them in clinics since 2017. And green is, we did a biopsy and it was a benign result. The number of patients with benign results have decreased because we send less patients, not just PTEN patients, all patients, for biopsy. So there are resources, centers of excellence that the PTEN Foundation defines. We happen to be one of them. We have about 120 patients right now with PTEN. And then there's web-based. Gene Reviews is a great resource, AACR, which I showed you those guidelines. And if you're going to hit Google, there's actually Google Scholar, which is a little bit refined and helps take away some of the non-scientific information for you. So none of this happens at my center. I'm lucky, like beyond lucky, to have a huge team that helps me clinically, have many people that we've worked together now for 14 years and actually have a clinical research team. You don't need all these people at every place. You just have to find 1 or 2 people that understand the disease and then have people that help them decide on how to read an ultrasound, where do they get their biopsies, who does their surgery. Again, in our center, and this is not to say everyone has to come to Philly, because everyone has different resources and we can't see everybody, but we have published data what the complication rate is, and we're at about 1 to 2% complication rate. You should know that from your surgeon if and when you decide to do surgery. And this is the CAT-C that we mentioned. So in an effort to make it easier for families, we're trying to get centers to work together, to have a registry, to decide together what's the best way to treat patients with thyroid nodules and thyroid cancer, whether it's sporadic or PTEN associated or DICER1 or anything else, and not just in North America, but globally as well. So with that, I'll end. And I know we have a time for questions and answers during a session, and I'm happy to take them then rather than now, so we can keep moving forward. Thank you.
Dr. Bauer, if you're still with us, I was going to give you 2 quick questions real quick
Sure.
from the folks. I'm trying to
Yep.
get in front of the camera so I can be a part of the team. Oh, shoot, Kristen, your screen went off. Darn it.
Is it in the chat?
It's in the chat. We've got one about total thyroidectomy and what it does to your, can you pull it up real quick?
Yeah.
Thank you, ma'am. That's not it.
So I have it. I can.
All right, great.
Has there been any study on post-surgical total thyroidectomy, PTEN patients in processing synthroid? Is there a tendency for people to remain stable or have variable TSH? I don't think specifically there's been any, it's a good question. And there are a couple different groups of patients. Some patients that have fluctuation in their TSH that may have to do with compliance, or it might have to do with absorption, depends on the form. And then there are some patients that, despite having a normal TSH, still don't feel normal. And those are somewhat different questions, but they're really important questions. Because anytime we change our body, even if I say, well, it's relatively straightforward to treat hypothyroidism, it's one pill once a day. People that have either of those two situations know that's not that simple. And it's not that simple in about 15%, not PTEN related, overall 15% of patients. They don't feel the same after that they felt when they still had their thyroid. So another reason not to just run into getting surgery. And it hasn't been specifically studied in PTEN, but there's different formulations now for thyroid, some that are less impacted by food. There's liquid preparations besides pills that are FDA approved. They're commercially produced as a solution, not as a suspension. And things that we could talk about, thyroid hormone replacements. And it's a great topic, but one that is a little bit complicated, but important. The
Fair.
second question is, thank you, my son with PTEN has thyroid nodules discovered by ultrasound at age 4. Yep. How often repeat the ultrasounds concerning his age? Without reviewing the ultrasounds, it's hard to provide a specific recommendation, but I'm happy to look at images. If we get to that situation, even we can figure out somehow through the PTEN Foundation. So if the nodules are just cysts, then we could take a little bit less of an intense, which would be annual ultrasound pattern. If the nodules look intermediate, probably annual. And if they look concerning, which would be unlikely in PTEN, that would change it again. So I really have to look at the images to help to decide that, and maybe through the PTEN Foundation, we can arrange that.
Excellent. Thank you. Very fair answers. We appreciate it.
Yeah.
Ladies and gentlemen, Dr. Bauer.